A pediatric patient arrives with a harsh, barking cough and severe respiratory distress. You can see the intense effort required just to pull air in, marked by deep, severe retractions between the ribs and above the collarbones. In cases of moderate to severe croup, this level of airway compromise requires immediate intervention, indicates severe airway narrowing. Before initiating treatment, gather your supplies at the bedside. You need the Racemic Epinephrine solution, normal saline for dilution, a standard nebulizer setup, and continuous cardiac and pulse oximetry monitoring equipment. Correctly identifying stridor at rest is your diagnostic threshold. It tells you exactly when humidified air and supportive care are no longer enough, and you must shift to immediate pharmacological treatment. For a standard nebulizer dose, you will draw up exactly 0.5 milliliters of 2.25% racemic epinephrine. This medication cannot be given straight. You must dilute it by combining it with 2.5 to 3 milliliters of normal saline directly in the nebulizer cup. This precise dilution prevents severe cardiovascular delivery errors. A single dose is often effective, but if respiratory distress continues, you can repeat this administration. You must wait a minimum of 20 minutes between doses. Alongside the nebulizer, you must administer dexamethasone. This steroid co-treatment is non-negotiable for any patient receiving racemic epinephrine. This clinical dosage reference card shows the standard protocol. The weight-based dose is 0.6 milligrams per kilogram, capped at an absolute maximum of 12 to 16 milligrams, depending on your specific institutional guidelines. The steroid is required because racemic epinephrine only provides temporary relief. Dexamethasone actively targets and reduces the underlying airway inflammation, preventing the symptoms from returning hours later. The precise dilution of the nebulizer ensures immediate, safe delivery to open the airway right now, while the steroid serves as the definitive, longer-term fix for the pathology causing the swelling. Start the nebulizer flow at an appropriate air or oxygen rate so the child breathes the mist steadily, and administer the oral or intravenous dexamethasone dose concurrently. Inside the throat, dilated blood vessels in the subglottic mucosa physically restrict the passage of air. As vaporized racemic epinephrine contacts the tissue, it causes aggressive vasoconstriction. The subglottic edema shrinks dramatically, and the central airway widens, restoring normal oxygen flow to the lungs. You will typically see visible clinical improvement in the patient's breathing within 10 to 30 minutes of starting the nebulizer. Because epinephrine is a potent stimulant, you must monitor the patient continuously for 3 immediate side effects: tachycardia, an abnormally fast heart rate, hypertension, and physical tremors. The drug provides rapid, mechanical relief to the airway, but it temporarily masks the underlying inflammatory state. This demands vigilant, continuous observation of the patient's vitals long after the nebulizer finishes. Patients must remain monitored for the strict 2-hour observation window following treatment. Near the end of this window, the epinephrine's vasoconstriction wears off before the steroid peaks. The airway can rapidly swell again, causing a return of severe breathing difficulty known as rebound stridor. If the patient experiences a recurrence of increased work of breathing or stridor at rest during this time, you can safely repeat the nebulizer dose, provided the 20-minute interval has passed. This flowchart outlines treatment failure thresholds. If the patient requires 3 or more doses to maintain an open airway, you must escalate care. You must also escalate immediately to ENT or the ICU if you observe hypoxia or persistent stridor at rest despite treatment. A poor response to treatment means you must broaden your differential diagnosis, evaluate the patient for severe anatomical blockages, a lodged foreign body, or infectious alternatives like bacterial tracheitis, which is a rare but life-threatening bacterial infection of the windpipe. The 2-hour observation window functions as a diagnostic stress test to separate standard croup from life-threatening conditions requiring ICU or ENT intervention. A successfully stabilized patient will rest comfortably after the 2 hours have elapsed. You will see a steady, smooth chest rise and fall, entirely free of retractions or noisy breathing. Achieving this result requires strict adherence to the exact 0.5 milliliter dosing and 2.5 to 3 milliliter normal saline dilution ratio, paired with the mandatory dexamethasone co-treatment. To prevent out-of-hospital airway compromise, the 2-hour post-treatment discharge rule remains absolutely inflexible. Once the window clears safely, finalize your documentation. Record the exact times of all administered doses and the patient's continuous vitals, before initiating your specific institutional admission or discharge protocols. Following this strict sequence of dosing, co-treatment, and observation, create a predictable, safely managed clinical workflow for a high-anxiety airway emergency.